For the next topic, may I request our chairperson, Dr. Arul Kumaran sir, to please come onto the stage. And I take great pleasure in inviting Dr. Vaman Khadilkar. He will now talk on bone health and growth optimization in children with disability.
At the outset, I would like to thank the organizers for giving me the opportunity to share this session. So, over to the topic. So, pediatric healthcare providers play a very important role in optimizing bone growth in children, especially children with disability. We also come across many children with disability whom we will be bothered only on physiotherapy and exercises, but least about the adequate bone mass. So, to highlight more on this topic, we none other than a very important speaker today. We have Dr. Vaman Khadilkar. Sir doesn't require any introduction. We have already listened to his talk today morning on updates in growth charts, where sir has given various inputs on how to make even mid-parental height very simpler and easier. We're looking forward, sir, today to learn some useful inputs on today's topic of adequate bone mass and growth in children with disability. Over to you, sir.
Thank you. Thank you. Can you all hear me? Can you all hear me? See, I'm going to talk on a very different topic today. Generally, I speak on pediatric endocrinology and growth charts. But today, this is a topic which is relevant to developmental pediatricians, pediatric neurologists, and this has now emerged as a new branch of pediatric endocrinology. So, bone disorders is now a sub-branch of pediatric endocrinology. So, this is something very different. Generally, pediatricians are not exposed to any information like that. Your bones we consider as a tissue in the body which is not particularly dynamic or acts as a dead skeleton, as an infrastructure of your body. So, your bones are not just dead things sitting there in your body, but they are actually dynamically being updated all the time. So, your calcium in the blood, as you all know, is maintained by exchanging it through the skeletal system. So, it's in dynamic equilibrium all the time. So, bone is constantly being remodeled. It's not a tissue which just sits there. Now, as people age, their appearance changes, their bones widen. Why? Because the process of bone formation is very different. Bone always takes away a layer from inside and puts it on the outer side. So, therefore, your bones are actually expanding throughout life, although they are in a dynamic equilibrium. So, as you age, your face, your features, even your pelvis and other structures start looking a little wider. So, remember, what influences your bone health or your bone mineral content is actually your genetics. 80 to 90% of your bone health is related to genetics. And of the environmental factor which is particularly relevant to a child with disability are these, or even in a normal child. Weight bearing. See, if you put a limb into a plaster and a child is not using that limb, after 6 weeks you take an X-ray of that limb and you find that the bones are completely osteoporotic. So, weight bearing is a very important natural means of getting mineral into your bones. Physical activity, athletes are supposed to have very good bones, and they do have it, because muscle and bone is a single mechanical unit. The more a muscle contracts, the more healthier your bone will be. Similarly, your diet, good quality protein, calcium, vitamin D, magnesium, zinc, vitamin K and C, all are important for your bone health. Then things which adversely affect your bone include medications such as anticonvulsants, steroids, antacid, proton pump inhibitors, and GnRH analogs which are used to treat precocious puberty. And then disease. Any disease that affects the muscle strength or muscle mass, any disease or neurological disorder that leads to reduction in the muscle strength is going to cause weak bones. Similarly, anorexia, celiac disease, cystic fibrosis, homocystinuria will lead to osteoporosis. Now, we have published from our unit in Pune how bone health is affected in multiple disorders that lead to either delayed development or disability. That includes growth hormone deficiency, Turner syndrome, syndromic children, Russell-Silver syndrome, and many other similar disease states. So a lot of hormones, nutrition, and bone muscle unit together manifests as your bone health. But why are we worried about bone health in children who are disabled? The reason is one of the major impact that disability leads to is on your bone health. So children with disabilities are far more susceptible to low impact fracture. Now what is a low impact fracture? A trivial trauma causing a fracture. For example, if you are playing rugby and a player falls on you and you break a bone, that's normal. But somebody just pats on your back or pats on your arm and you break an arm, that's a pathological fracture. So low impact fracture, especially in the lower limbs, your legs are very strong normally. So that is very common in disabled children. So as I mentioned earlier, what are the factors which are specifically happening in disabled children? So they have poor nutrition. As you know, children with cerebral palsy, children with muscle disorder have problem swallowing, they have problem chewing, they have reflux. So together, this leads to very poor nutrition. They have very limited or complete lack of weight bearing. Most of the children cannot stand. Use of medications, they are under so many medications. Many of these are on anti-epileptics. So they are not only directly affecting the bone health, but also acting through lowering the vitamin D content. They have limited intake of calcium as well as sunshine exposure is often non-existent. These are wheelchair bound, homebound children many a times. So together, these factors cause poor bone health in children. Can you change the slide for me, please? Thank you. Right, thank you. So what are the conditions that are known to be associated with poor bone health? Commonly what we see in our pediatric endocrine unit is children referred with bone disease for cerebral palsy, muscular dystrophy, and spina bifida. These are the commonest referrals in disabled children. Normally we see a whole lot of rickets, resistant rickets, osteogenesis imperfecta, but in disabled children these are the common conditions. And now I want you to focus on this particular slide. I have shown two bone radiographs here. And I want you to understand the basic structure of the bone. So the bone has got cortex, which is the lining that you see above the metaphysis. So the diaphysis consists of cortex, whereas the epiphysis and the metaphysis consist of trabecular bone. So trabecular bone, as you can understand, is more like a sponge, but a hard one, like a coral, you can say, like a coral. Whereas the trabecular bone is like a iron pipe. Cortical bone is like an iron pipe. So within the femur, you have two different structures of the bone. And then there is an area where transition occurs. So if you understand the bone structure first, it's much easier to understand what I'm going to tell you subsequently. Now, how do you assess bone health in children? What are the methods? There are multiple, right from ultrasound to MRI to X-rays, the routine X-rays, to the gold standard of DEXA. What is DEXA? DEXA or DXA? Dual Energy X-ray absorptiometry. That is DEXA. And that's the gold standard. But as I said, you need to understand the two basic types of bone differently, trabecular and the cortical. Now, definition of bone density. Now, if you say that Indians have bones which are less dense than the black Africans, what actually do you understand by that? What you understand by that is that the mineral content per unit volume of bone is low in Indians when compared to that of, say, Caucasians or black Africans. So the density is the measure of volumetric bone mineral content. But DEXA measures your areal density. Areal. Now I'll explain this further because this concept is very important to understand. Now that's a DEXA machine. We have this iDEXA fan beam. Our unit has 3 DEXA scanners now, and we also have a peripheral computerized tomography for what is known as PQCT, for volumetric density. But what you commonly will see in your practice whenever you send a patient for bone density assessment is report given by a DEXA machine. So you need to understand the make of the machine, the X-ray source, and the reference data for that particular population. So what happens is that the patient lies here and the source of X-ray moves from head towards the toe, and as it moves it gets images and measures areal bone density. And now I'll explain to you what areal bone density is. But before that, I want you to, even if you take home this one message, I'll be happy, that do not look at the T-scores given by DEXA scan. T-scores are meant for adults. So what you actually are looking at is comparison of the patient's bone density to a 25-year-old young adult of the same gender. So it's completely useless in children. So do not look at the T-scores for osteopenia, osteoporosis or normal bone. Do not look at any report given to you by some relatively substandard laboratories that also do bone density for your patients and give you a peripheral bone density. There is absolutely no correlation whatsoever between the peripheral bone density and the actual bone density in pediatric practice. So remember this. Even if you take home this message, I'll be happy. So what do you look at in children? In children, you look at the spine. At all ages, except of course very young infants, you can read the spine bone density. And second thing is, you can read the femur density after 10th birthday. Children beyond 10 years can have an assessment of the hip. What the report that you get in children is total body bone density minus the head. So you often get TBLH as a report, total body minus head, or total body less head. So head cannot be measured, rest of the body gets measured as an entire bony structure. So that is something that you must also look at. And then the modern machines like the one that we have and many laboratories have is what is known as VFS, vertebral fracture study. So here a lot of children with disabilities have silent vertebral fractures. They can't speak, they can't tell you, but they're because of the muscle disorders that they have, often the convulsions that they have, they develop compression fracture of the vertebrae because their bones are also poor. So as I said, DEXA is the gold standard. It gives you areal bone density and not the volumetric bone density. Now children with disabilities may be so badly disabled that their spine may not be straight, their femurs may be broken, and you often do not know, and they cannot even lie flat on your DEXA scanner. So you don't know which bit to measure. Remember, in most disabled children, the femur lower end is always very well preserved. And therefore, lateral distal femur is recommended for site for children with severe disability. So you make them roll over on one side, and then you measure 3 areas of interest. 1, 2, 3, as I said. At the bottom, you are going to look at the trabecular bone. Second, R2, you are looking at a transition between trabecular and cortical bone. And R3 is you are only looking at the cortical bones. And each one has a defined norm as per the age. Now, these are the difficulties in performing DEXA scan in disabled children. If you look at the problems that these poor kids have, it's very hard to get a DEXA. They move a lot, they have contractures, they have scoliosis. Often they have metallic implants, they have a feeding tube, they sometimes have a pump, they have very high muscle tone, they are stiff, they cannot relax, they get startle reflex, many of them are obese, many have cognitive delays and don't understand the positioning you are giving, and a lot of CP children have dislocated hips. So considering all this, it's actually easiest to do the lower end of femur in many children who are disabled for bone health. How do you interpret DEXA? As I said, these reports are called as bone mineral density or bone mineral content, but it's an areal bone density that you get. Anything which is less than -2 is abnormal, or anything more than +2. There are some bony disorders like the Paget disease or osteopetrosis, where your bones are very, very, very heavily mineralized, although they are not necessarily solid. So anything between +2 -2 is normal. Anything beyond that is abnormal, like in any other biological parameter. So BMD Z scores and not the T scores are to be used in children, as I said pretty emphatically earlier. And children whose height and weight are below the 5th percentile have short bones. So they will always get poor bone mineral density scores. So you need to correct for the child's height. There are formulae for that. So child height should be taken into consideration if it is below 5th percentile. How do you diagnose osteoporosis in children? International Society for Clinical Densitometry, ISCD, has defined pediatric osteoporosis that there must be a fracture to call osteoporosis. So just based on the DEXA scan report, you cannot diagnose osteoporosis in children. This is the second take-home message that I would like you to remember, that without a fracture, there is no osteoporosis in children. So you must have a fracture. So vertebral fracture, even one, is abnormal. In the absence of vertebral compression fracture, the diagnosis of osteoporosis is indicated by the presence of a clinically significant fracture and a BMD score, which is less than -2. And a clinically significant fracture is 2 or more long bone fractures by the age of 10 or 3 or more long bone fractures by the age of 19, generally with low impact. And as I said earlier, you need to know your machine and your data. So we have published normative data for DEXA scan on Indian children, and you can get it in the Journal of Bone. Now, I'm going to spend only a few minutes on this volumetric bone density versus the areal bone density. I'm not sure, many of you may not be able to read from there, but you can see this picture. This is how the DEXA beam actually projects the bone. So if you have a bone, like on the left side, a small bone, then although your volumetric density is 2 gram per centimeter square, DEXA is going to give an areal density of 4 gram per centimeter square. Whereas in a larger bone, with the same volumetric density of 2 gram per centimeter cube, the areal density works out to be 6 grams per centimeter square. So both bones are actually equally dense, 3-dimensional. But DEXA is going to score short and thin bones as bones with less mineral density. So you must understand this fallacy and correct it. There are a variety of equations, but remember, in children with short bones, with thin bones, you have to be careful, and you should then adjust the given bone mineral density for these differences in the length and the thinness of bone by using appropriate formulae. Now, these are the causes of disabilities that lead to secondary osteoporosis, and there is a whole lot of them, and I'm not going to read through that. You can read them in books. These are typical fractures in children with cerebral palsy. They get dislocated hips, and the lower end of the femur is the commonest one that gets fractured. Very osteoporotic bones. These are the vertebral fractures in a child with cerebral palsy a year ago, and after giving zoledronate, the vertebral fracture completely improves within 1 year. And even the size of the vertebra, and you can now see the bisphosphonate lines. These are the bisphosphonate lines. So how do you treat osteoporosis? That's what I'm going to tell you in the last minute or so, because there is only this much you can do. You improve their nutrition, give them proper protein, vitamin, mineral, calories. Calcium, total 500 to 1200 milligram per day must be given to all children, but more so to children who are disabled. Children on anti-epileptics will need 2 to 4 times the normal vitamin D dose. Physiotherapy is very important because passive and active exercises will improve bone mineral density. And bisphosphonates remain the cornerstone of management. You can give the children zoledronic acid in a dose of 0.4 to 0.5 milligram per kg IV every 3 to 4 monthly over a period of many years. And recently, people have started using low intensity vibrators. So you make the child stand on sit on a vibrating machine, and that improves the bone mineral density. So these are the modalities that you can use to treat osteoporosis. This is our team at Jahangir Hospital. That's of course my better half, Dr. Anuradha, who has a lot of studies on bone. That's our team, that's me in the middle. So thank you. If there are any questions, please write to me at vamankhadilkar@gmail.com.
Thank you, sir, for an excellent talk on bone mineral density. So I have one simple doubt, sir. When ideally we should do DEXA in children with disability? Okay, is it routinely should be done, and when we should do?
I think all disabled children should have at least one DEXA scan done. And if you do diagnose osteoporosis, then the repeat DEXA should only be done after a year. There is not much point in doing 6 monthly. Like a lot of orthopedic surgeons would ask 3 monthly, 6 monthly. You don't see any bone mineral content improvement.
How much it costs, sir?
Cost is anything between 1,000 to 3,000 rupees, which is not exorbitantly high.
Thank you, sir. Any questions from the audience are invited?